Hi, so I am doing my individual reflection video on the pediatric simulation. So I would say going into the simulation, I kind of felt more nervous than my other ones. I don't feel as comfortable in like a pediatric setting as I do dealing with adults. Like I just don't feel like that's my natural strong suit. So it does make me more nervous, but I do think it is kind of good to be nervous going into a pediatric setting just because you do need to be so careful with kids and with medication administration, and there's just like a lot more risk factors with them, and there's a lot more area for you to kind of make mistakes and stuff. So I guess it is good to have a sense of nervousness, but I definitely don't feel as comfortable, so I was a little nervous. I do feel like I have a really good understanding of diabetes and kind of the care of it and education and all that goes along with it. But I would say my education is stronger with like adult diabetes just because I already had my exam on that and I learned all that material, where we are just soon having our exam for pediatric diabetes and all of that, so I'm still kind of studying that material and learning it right now. So it is a little fresh in my mind, and it's not like completely, I guess, like long-term memory yet. So yeah, but I mean, when I did my first SBAR and we went through that as a group, there really wasn't much information you were given, especially since when we did our SBAR, we only thought we were supposed to watch like the first little bit of the segment, not the whole clinic visit. But yeah, I feel like we didn't really see much like going drastically wrong with the scenario, which I don't think anything really did. I think it was basically kind of to teach us about like patient education and developmental considerations with like pediatric patients. So my first question is, reflect on any ethical dilemmas uncovered during the scenario and describe how you might respond differently based on the situation. Provide evidence-based resources to support my answer. So again, with this scenario, like going through it and reading back over it, I didn't identify any ethical scenarios. I would say that the nurse handled like everything in their scope of practice and in an ethical way. They provided continuous education, and that's both the nurse in the hospital and the nurse in the clinic. The nurse in the clinic especially was very communicating to the provider. I don't think there was as much communication to the provider like on the screen for in the hospital part, but there was nothing ever done that I thought like, oh, that's not right, that's not how that should be done, or even so drastic to the point where it's like unethical what they were doing. Yeah, so I didn't really have a big problem with that. However, I did have some things that I felt could be done differently and a little bit more effectively throughout the scenario. So I'm just going to talk about those right now since I don't have any of the ethical dilemmas. So my one thing is, I know I did say that the nurse in the hospital, he did provide education throughout the length of the stay. However, I'm just not quite sure if I thought that the way he delivered the education was as effective as it could be. So obviously when you have this pediatric patient that's dealing with a new diagnosis of a lifelong condition like diabetes, they're going to be experiencing fear, anxiety, probably feeling a little overwhelmed and sensory overload from the hospital setting. You can tell, like, even when they talked about admitting him to the hospital, like, he didn't want to go. It was kind of freaking him out. So you definitely have to take that into consideration. And I was reading an article on patient engagement HIT, which kind of helps understand, like, teach people how to educate based on, like, the condition and the developmental group. So some big takeaways I got from that were that when dealing with a pediatric patient, you need to take a more creative and effective approach to education than you typically would with your adults, and this can help decrease the anxiety in the patient as well as improve your outcome and the education level at the end. So you have to understand that this patient, because they are 12 years old, they're going into adolescence, they're going to be fearing separation from their peers, a lack of control and independence in their life. So that goes along with just the fear and anxiety of the new condition and being in the hospital. They also have this fear and anxiety about not fitting in and not being with their peers. So your education really has to be geared towards calming their nerves as well as addressing their developmental concerns and their age group, because with an adult this isn't as big of a problem because their age group and their peers, majority know what diabetes is, they know people with diabetes, it's not a big deal of fitting in. Whereas when you're a 12-year-old in middle school, fitting in is a big deal, and if you're the only one with diabetes, you'll feel a little singled out. So your education should be geared towards, helping them with that and letting them express their concerns. Also, it really helps for kids to be hands-on, which the nurse actually did do. He brought in one of the little skin dummy thingies that we actually do use in our labs, and he allowed him to practice the injections on there. I'm guessing he allowed him to practice the finger stick too, even though that wasn't shown. And then probably just allowed the mom to practice and as well, so then they can demonstrate back to him that they effectively know how to give the injection. You also are going to want to provide developmentally appropriate material. I'm not quite sure if this was done in this scenario. I know he was providing a lot of material to the mother, but I didn't really see him provide anything to the child, which was kind of a concern to me just because he is capable of having papers or even having his own binder that's maybe engaging for a child, something that's laid out in more of a fun, creative way. And also this can be helpful considering he is going into his teenage years. He is going to start really wanting that independence and control. So it's helpful to be gearing this education, yes, towards the mom, but also a lot towards this kid due to his age. You want to make sure, too, in your hospital stay that you're helping maintain their routine. I guess they kind of did that here. He was still reading his books and playing his games. Another thing that kind of bothered me, it didn't really look like he was on a pediatric floor. I know when I was in my once ped rotation, I just feel the floors were and the rooms were more inviting and comfortable for a child, whereas this room was very sterile and a little bit I feel like a kid wouldn't feel as much comfortable. So I think that could even play a factor in his anxiety and his fear as well, because that is a big thing in your pediatric patients, making sure their rooms, even if they he wasn't there long enough to need to make it look like home or anything, but it didn't even really look like a pediatric floor, which maybe they just don't have access to one, but I noticed that. With your education too, with kids, you can use videos, you can use booklets, tools, mock tools. I didn't see them use any videos or anything, but I thought that could be a good thing with this child because you could see that he was pretty interested in his games and stuff. So if you provided a video on a tablet or on the TV, he'd probably be more interested in that than just listening to you or reading a piece of paper. I also read on this website, the article, that you can also use modules which are more interactive and ask questions, which kind of put that child into an active learning state and allow them to be more engaged. And then also, I think your education with pediatrics is a lot about teamwork. I didn't really see them have any child life specialists or anything come in, but I think that can be beneficial for this family just to allow them the support they need. And my last thing is that I didn't really notice them educate that much on hypoglycemia prior to his hypoglycemic attack. I think it's really important right when you get this diagnosis to, yes, teach them about everything, And make sure you're including your hypoglycemia and hyperglycemia signs and symptoms in there so that when he does start going into this state, the mom isn't really freaked out and doesn't understand what's going on. She'll have more of a calmness because she knows what's going on. And yes, she's still going to need the nurse to come in and help her, but at least she's not going to be panicking thinking what's going on with my child. And overall, if you provide this education in this manner, it just establishes a trust between the child and the parent and the healthcare team. So yes, he did provide good education, but these are just some improvements I think I would make to it personally if I was a nurse in this situation, and how I would kind of gear it more to be interactive with the child. Okay. So moving on from that question, the next one says to describe an aha moment you experienced during this learning experience and how it will expand your nursing care. So there wasn't any, again, kind of similar to the OB one. I didn't have a huge aha moment just because like going in, you see the name of the simulation, like you kind of know what's going on. Also, his didn't take any like really big deviations from I think an expected care for a pediatric patient with diabetes. So it was a little bit like kind of like a predictable track of care, I guess I could say like that. But one thing that did kind of was like, aha, his hypoglycemic reaction, I could identify it right away based on the symptoms he was displaying, even before the nurse said what it was. That kind of made me feel confident in what I've learned in didactic, in my clinical practice. I also knew that you would always treat it with carbohydrates or some orange juice before you ever give a medication, and I know that you always use your oral medication before you use your injection, and the injection would only be used when he's unconscious. So of course right away I identified those symptoms, and then before answering the question about how we would treat him, I analyzed, is he conscious, is he awake, like does he have the ability to swallow or eat something. And thankfully he wasn't at the point yet where he needed an injection or anything. He still was conscious, so we were able to make clinical judgment decision on that and decide what was the best option for him. But it was kind of an aha moment that I was able to identify the condition and what was going on right away just from the symptoms the patient was displaying. The second aha moment I had, so throughout the scenario, I kind of thought, as I addressed in the first thing, that there was kind of a lack of education as well on how to like handle his diabetes management in the school setting or when he's with friends, because obviously during his age, which I have on here what his current stage is. So his Erickson's developmental stage was industry versus inferiority. So this is a lot of like fitting in and humility, embarrassment, which was indicated in the beginning when he was really embarrassed about the bedwetting. So it's easy to predict as a nurse that due to the stage he's in, that he's all likely going to feel embarrassed, like with his diagnosis in front of all his friends, checking his blood, administering insulin, all that. So I almost like, it kind of frustrated me because I didn't feel like there was enough addressing of that during his hospital stay. And then when he came back to the clinic and they were complaining that he was feeling uncomfortable addressing it with his friends, and like he didn't want to check his blood glucose anymore when he's at school or when he's at his sports, I almost wanted to be like, I knew this was going to happen because of the lack of education he was provided regarding this in his hospital stay. They kind of just address like the disease, but they need to take in consideration like this isn't an adult or adult diabetes we're dealing with. So that was an aha moment, kind of because I predicted that one coming, and I kind of got to see it come into like fruition. So that was another moment. And again, like I identified that needed to be a part of the care. So I know that in my nursing care, in this type of situation, I am going to expand my education just beyond like factual knowledge and help that patient like express their emotions and maybe ask them like what they would feel most comfortable doing in the school setting. Like, do you want us to reach out to your school nurse or like your school, and we can have you be able to go into the nurse's office to pull to draw your blood and inject your insulin. And then it also gives us the verification that he is doing that at school, because that is one of the concerns with this age, is that they're going to forget to do it or just not really care because they don't understand like the priority of it. Okay, so now moving on to the next question. So this one says what are some aspects of client care that you didn't feel prepared to make clinical decisions for in the scenario and or after completing your nursing care plan? So I think after we completed our nursing care plan, like the very initial one, and we were doing our SBAR and everything, our main problems were like fatigue, weight loss, and bedwetting. So it was mostly just surrounding his symptoms, since we didn't have any diagnosis yet, so we couldn't have any of that as our problems. So I mean, I just didn't really know anywhere to go from this besides hopefully that it would all come under control once we got his blood sugar under control. But after we were able to talk it out and everything as a group, we know that you're going to monitor that it's going away once his blood sugar is more under control, but you also need to be making sure there's no underlying causes of this. Like, you want to identify his sleep for fatigue, like you're going to be identifying the sleep patterns, making sure that he has a good sleep routine. For weight loss, you want to make sure that like his nutrition has stayed well, that he's not having an unbalanced diet. So in our nursing like responsibilities, we want to make sure we're identifying the causes and kind of eliminating out any other causes. So that was kind of going in. My problems, I didn't really know exactly how to address them, but I was able to narrow that down and figure it out with my team. And then my other problem list that we had during his hospital stay, our main priority was, of course, his diabetes, controlling his blood glucose. We wanted to, start that therapy and educate them on it, and then also still be dealing with those symptoms to make sure that they're going away and that there's not another underlying cause. Again, something I think I wasn't as prepared for with this care plan. Sometimes I think I kind of go out of my scope of practice, and it was helpful to talk to Miss Osborne about this because she kind of helped us understand like what is in our scope of practice and what is beyond it. So obviously we can initiate that therapy once we get the orders and educate on it, but we're not going to be saying like diabetes management therapy, because that would mean that we're planning the therapy, which isn't in our scope of practice. So that was something I kind of was able to understand more for this. And then throughout the scenario, some things that I didn't feel very prepared for. So I know I said before that like his hypoglycemic episode, I was able to I identify what it was and know how to treat it, but it did take me kind of surprised when it happened. I guess I just assumed with his insulin therapy was on and the close monitoring in the hospital that he wouldn't experience a hypoglycemic reaction, but looking back on it, it does make sense considering he is a newly diagnosed diabetic and they're still like figuring out which dosing and everything works best for him, and the diet that goes along with it. So it does make sense looking back, but I guess at first I was just thinking that they would have it under better control, but it's still kind of like a period of figuring out what works best for this patient and his lifestyle. Another thing I wasn't prepared for actually was for him to get diagnosed to the hospital. Before this scenario, I never really put two and two together that like when a child's getting diagnosed with diabetes that they're likely going to be admitted into the hospital. And this is due to, looking back, I know this is due to the fact that they need to have confirmatory lab tests that aren't just done one day in a clinic. the education definitely takes an extended period of time to go over. Like, you can't just educate them in one quick clinic visit and get all their medications. It's kind of like an overwhelming amount of stuff, so they definitely need to be somewhere for a few days. And then also, by the time they probably eventually get this diagnosis, they probably have pretty a very elevated blood glucose, so they're gonna have these negative effects going on, such as with Derek. He had the fatigue and the weight loss, and the fatigue was to the extent like he wasn't playing with his friends, he was wetting the bed, he was hungry, thirsty, frequently urinating, so it was really affecting his everyday life. So he needed to get admitted to the hospital and in order to get his glucose under control, to figure out what dosing works best for him. With the hypoglycemic episode that happened, you want that first one to be in the hospital, I'm guessing, to be able to control it, all of that. Your education is continuous throughout the whole stay, so it does make sense looking back on it. But at first I was like, oh, I didn't even think that you would need to go to the hospital for that first diagnosis. Another thing that took me by surprise was just kind of not the lack of knowledge of the knowledge deficit of the child, but kind of more of the parent, the mom. I guess just because I'm in nursing school, like my mom was a nurse, I had family with diabetes, I just thought people had more of like an understanding of the disease and like the management of it, but that's not really realistic, because some people may go their whole lives like they're not in the healthcare field, or like they don't know anyone with diabetes, so they just don't know anything about it. So that did kind of surprise me, but it was like a realistic, eye-opening event, because just because it's familiar to me and maybe to like people I know doesn't mean it's familiar to everyone. And that's why you kind of just have to approach everything like it is a new condition, like it is something they don't know about, kind of assess their level of knowledge of it, and then provide it at that simplified level so they're able to absorb the knowledge and understand it, and to just never be like judgmental or critical because of the knowledge deficit, because just because we have that knowledge or our family doesn't mean that other people do. So you should never expect your patients to know about diabetes just because it's a more common condition. The other thing I was kind of surprised about, it was just harder to educate him, I noticed, because he was always very distracted, and I know that's very common for a child his age to want to like just be on his game, on his book, and not really listen. I guess I kind of thought that mom would make him be more engaged in your education, but she didn't, except one time, really. And I don't know, I don't really think it's the nurse's place exactly to be like, get off your game. I mean, you can do your best to educate, but I think that kind of falls into the role of the parent. But I know as nurses, we are required to make sure like they have the education at the end of the day and have them get their feedback. So I guess like you could educate to the best of your ability, while even though they're like kind of acting distracted, and then you could ask them, so like, hey, like, can you tell me like what you would do if this happened, or like, so can you tell me some of the symptoms of this? And then if they're not, I guess if they still don't know, you could be like, okay, well, this is really important, like I need you to know this, so I'm gonna go over it again, and then ask. I'm thinking maybe that's a way, maybe then their mom would ask him to put the game away, but it is kind of a sticky situation because it's hard to like educate them when they're not paying attention, but then you don't want to overstep your place and be like offensive or anything. So that was something I wasn't really prepared for. The last thing I wasn't prepared for, so I knew that we had to consider his like developmental stage with his education and like help prepare him for going back to school and stuff. I understood too, like the feeling of like not fitting in and stuff with his diagnosis and like having to draw your glucose and stuff, but I didn't really expect like kids to be like making fun of and bullying about it. I guess I just forget because I'm older now, kind of sometimes what it's like for kids, and just they always just want to know what's going on. They're like intrigued, and sometimes I think they don't have a filter with some stuff, so they say things like that. So it is important to always consider that as a possibility, and just be like very supportive and allow your patients in the pediatric age to like express their emotions and just be there for them, because that is hard being a kid with a condition that like no one else has. So that was something I wasn't really expecting from that. Okay, so the next question says to describe 3 to 5 important concepts I learned from the scenario, and then describe how I will apply my knowledge of each concept to future client situations. Provide evidence-based resources to support your response. Okay, so my first thing I learned from this is, I've kind of touched on this a few times, is the developmental considerations with your education. So I know this is important, but I kind of just felt emphasis through the scenario because I don't think it was exactly done properly, as I've said, but it kind of just showed me like what a lack of the developmental considerations in your education can do, and I could just see areas for improvement, and just how vital it is with your pediatric population, just because you want your patient to be interactive and engaged in the learning process. And I didn't really see that a lot throughout the scenario, and I think it really could have allowed for him to have a stronger education in it, and then also feel more independent with control of his condition. So when considering developmental considerations with education, I was able to find an article on the Wellness Network that says some ways to really help engage your pediatric population in their education is to use like technology, use the TV with videos. You can use tablets too that let them watch videos, or like modules, and they say that's really, really helpful in the clinic setting. Like while they're waiting, you can have them watching these videos or something like that. So I thought that was really cool. Also, I thought it could have been helpful to recommend like maybe some support groups, both for the mother and the child. I think that that's definitely something that could be done, and I think it's just from the scenario, I really know that in a pediatric setting, every step of your education along the way, it has to be engaging for like the family as well as the child, and you want to gear it more towards the child because it is his condition and he's the one that's going to be living with it, and you want to make sure that when he's away from home and not with his mom, like he's the one that's able to take care of it, because you've already given her the binder and like she can understand the level you're teaching him at. So I think the scope of education should be most geared for him. So that's my biggest takeaway from it, and something I know that I will be able to apply in my clinical practice. It's just always modifying my education to my patient, not just having a general education style for everyone, because that doesn't work. It's the same concept with learning in school. Like not everyone learns the same way, and it's the same way with your developmental considerations. Not everyone can learn the same way. And another thing I've kind of touched on before is about how he also should have educated on the diabetes with peers. I know I would have touched on that in my education for sure, because due to his developmental level and the fact that he's soon going into his teenage years, like it's really important to be educating him on how to handle this condition with his peers in the school setting, in the sports setting, when he's hanging out with friends, because that is basically his number one priority right now, is feeling independence, feeling control, fitting in, having a social life. And this kind of ties into my another thing I learned. My second thing that I feel like I learned is the need for psychosocial support with like the pediatric diabetes diagnosis and education, which kind of ties into like educating on the peers. So I think that it's a huge part of the care. It was definitely addressed in the second clinic visit when he came in and expressed his concerns. He expressed his concerns about like not fitting in and being made fun of and like not wanting to draw his blood glucose because he just feels like he's getting made fun of and he doesn't like it. It was addressed then, and it made me realize how important it is to not only provide knowledge and education on the disorder and how we're treating it and the hypoglycemic and hyperglycemic episodes, but we also need to focus on how it is hard for the child and obviously for their family or their caregiver to understand this new disorder and accept it. It's going to be shocking, the diagnosis. It's a lifelong condition, and it's going to bring them fear. It's going to make them anxious. It's going to be a little overwhelming. So we definitely want to help them. The provider can provide referrals. We can have help with the self-management support, so they're going to need help understanding how they're managing this from home and that they can do it, and it's very possible. You need that emotional support, so allowing him to express his emotions, allowing the mom to express their emotions. I mean, she's an only mother. There's no other siblings. It's her only child. It's definitely a hard situation, so it's so important as nurses that we are there for them, and we are allowing them to talk about how it's going to affect their life and how they feel about it, and then provide, some nursing advice, like interventions they can apply to help make it better. And also just to kind of be a shoulder to lean on and someone that will listen, and support them. So another thing is like your financial support. Obviously, that's most likely going to be a big concern with this mother as well, because of the fact, again, she's a single mother, so it could be really hard for her. So again, like allowing her to express her emotions on the psychosocial aspect of it, communicating those emotions and everything to provider, and then they can maybe recommend, or not recommend, but they can get some referrals or consults to come and talk to her, anything like that. I got a lot of this information off of the diabetes journal. It kind of just talked about the importance of the psychosocial aspect, and that's a big takeaway for me for my clinical practice and my practice as a nurse, because I know how important it is to not just address like the knowledge-based side of your education. Another thing I learned is kind of like how to handle a hypoglycemic episode, not necessarily like what you give and stuff, because I know that, but the more of like the way you should present yourself and how you should react to the situation. Because definitely as like a student nurse or like a new graduate nurse, it's easy to freak out at all different situations, but it's just so important to remain calm, as the nurse did in this scenario. He was very calm. He used it as basically like an educational opportunity. So once he was able to get his blood sugar levels under control with some carbohydrates, recheck the levels, make sure everything was good, he was able to use that as like an educational opportunity to, teach the patient and the mother about what hypoglycemia is, how you manage it, like the early signs of it, the late signs, and I think that's a really good way as well, because once they have that, they know what it feels like personally, and then you can always relate back to that, like remember how you felt, like, and they have such a better, deeper understanding. And I was just reading this article in Medtronic, and I was just talking about how important it is to use this as an educational opportunity with our pediatric patients, to remain calm, to decrease any anxiety. Obviously, our first step is always to use our carbohydrates and then move to the medication. But I know definitely it helped me realize kind of how to handle the situation professionally, which I would definitely carry out in any future clinical experience. Just the importance of remaining calm, because your energy definitely can affect your patient's attitude. So if I went into the room freaking out, the family and the patient is also going to start freaking out and feeling very overwhelmed. So the last big thing I learned from this is just the differences between our adult and pediatric diabetes. So as I said in the beginning, I'm very familiar with adult diabetes just from didactic and from clinical. I feel like so many of my patients on the medical surgical floors did have diabetes diagnoses. A lot of them were type 2. I read up on this a little bit more on diabetes and control. It really touched on the fact that with our pediatric diabetes, we always have to remember their development because that will change their needs over time. For example, our patient Derek, like his insulin needs are going to change as he gets older, maybe as he goes through puberty. He's eating more, he's growing, like his insulin needs will change, and the nutritional needs are going to change. So it's definitely a lot different as well than with our adults, because we're going to be creating, well, not necessarily us, the provider is going to be having to continuously change this diabetic therapy plan until he reaches an age where he's not growing anymore, and his needs are staying more consistent. That's when it will transfer into our adult care. But as a pediatric patient with diabetes, it'll definitely be changing needs for a while because he's only 12 years old. And as nurses, we really are going to have to adapt to the management that is transitioning from childhood to teenage years. So this kind of ties into the education I was talking about, because since he's soon going into those teenage years, it's such a big concern for us to make sure that he's well educated going into them and feels that sense of independence. Because if he feels like it, I mean, personally, what I believe is if he feels like his mother's in control of the whole thing and he doesn't really have any control over his own body and his disease, he's more likely to kind of like rebel from her and just not want to deal with it. Whereas if it's always been a condition that he controls and is his independence, and like obviously his mother is helping him, but if he feels a sense of independence with it and has his own knowledge on it, I think you're way more likely to have a consistency even as he goes more into his teenage years. He's less likely to be like uncompliant or anything like that. And that's just the big takeaway from that, is being able to like identify their developmental age, their considerations, knowing that their care plan will be changing, and the fact that they are becoming more independent. They're going to want control over things, so that is very important to remember with this age, is that we're not going to be focusing on educating the mom, because this child is capable of handling this disease, and in a few years he's not going to want his mom to be the one giving him shots or anything. He's going to want to be doing it all himself. So I think that's really important with our clinical practice. So that's pretty much it for my pediatric simulation. I feel like we did handle that one pretty well, picked up on any problems, felt prepared when we were answering the questions, worked well as a team. I really didn't notice any big problems, and I think it was a good outcome for the patient and a great learning experience for me.